So good morning. I'm Phil Landrigan. I'm the chairman of the Department of Preventive Medicine here at Mount Sinai. I'm delighted to welcome you all this morning to this special symposium on breast cancer and the environment. We've got, I think, a nice setup for you here. We're very deliberately multidisciplinary. We have a surgeon, we have an epidemiologist, and Bob Wright and I are both pediatricians. So we have people from three branches of biomedical science here this morning, and thanks to all of you for coming in, especially on such a rotten day. I know that it's just not an easy day to navigate about the city or to come down from Westchester or Connecticut or Long Island. So thanks to all of you who've come in. So what I'm going to do at the beginning here is talk for a few minutes generally about our Children's Environmental Health Center at Mount Sinai, why we have this center, the rationale for forming it, the context in which we operate, and then we'll segue from there into the topic of the morning, which is to explore connections between breast cancer and the environment. So we started this center because about almost 10 years ago now, because rates of chronic disease in children in this country are high and they're going up. Let me show you some examples of that. Asthma is the most common disease of children in the United States. Excuse me, and over the last 30 years, rates of asthma have more than doubled in American children. Asthma has become the largest cause of admission of children to the hospital. It's become the greatest cause of school absenteeism. And one of the things we've learned through our research and research that's been conducted at other academic health centers around the country is that a whole series of factors in the environment are powerful triggers for asthma. We know that indoor air pollution, secondhand cigarette smoke are powerful triggers. We also know that outdoor air pollution, fine particulate pollution from cars and trucks and buses and power plants, can initiate asthma in people that previously didn't have it and can aggravate asthma and precipitate acute attacks in children who already have the disease. So for all the diseases that we study, the environment contributes to a greater or a lesser extent. Childhood obesity has more than tripled, and we know that what's called the urban built environment, the absence of playgrounds, the absence of places for kids to exercise, the overabundance of fast food, the increasingly large size of food portions, all of those factors in the urban environment contribute to obesity. There's also a body of evidence that's developing that certain chemicals that are common in our environment, some pesticides, for example, may also push people towards obesity when the diet is equal, but one child is more heavily exposed to some of these chemicals than another child. The child who's more heavily exposed is at greater risk of obesity, called chemical obesogens, and that's an area that we're researching in our center. Childhood cancer. The good news on childhood cancer is that kids recover today. They didn't used to. Today, a very high proportion of children get over the disease. Of course, the treatment is brutal, but it works. But the bad news is that the incidence of the disease, the number of new cases per 1,000 children in the population, has been steadily increasing at a rate of about 1% a year since we started keeping national records in the 1970s. And one of the, not so much in our center, but in other centers around the country, people are digging into the question of what are the environmental triggers for childhood cancer. And then, of course, learning disabilities of all sorts, attention deficit disorder, autism, mental retardation, dyslexia, all of these conditions are very highly prevalent. And these national data that I'm showing on the slide here that come from the Centers for Disease Control show that autism is now occurring in one child in every 68. And we've learned through epidemiologic studies conducted here and at other places across the country that there are a whole series of toxic chemicals in the environment that contribute to neurodevelopmental disorders in children. We learned first about lead, then about methylmercury, more recently about pesticides, brominated flame retardants, evidence now coming in for phthalates contributing to loss of IQ in children. Unfortunately, we know today that children are exposed to many thousands of chemicals. Too few of these chemicals are tested before they go on the market, so children are exposed and pregnant women are exposed every day to untested chemicals, and then we learn to our chagrin after the fact, belatedly, that some of these chemicals can cause damage to children. So here are some data on that. There are over 80,000 chemicals that have been invented, brand new chemicals that didn't exist 50 years ago. These chemicals are widely used. We all are exposed to them every day in all kinds of products. Food wrapping, drink, construction materials, cosmetics, and they get into our bodies. When the Centers for Disease Control do surveys in the United States and go across the country and take biological samples from Americans, they find about 200 synthetic chemicals in all of us, in pretty much any American. Certainly any American that lives in a big city in an urban environment is surrounded by synthetic chemicals. And fewer the chemicals themselves are not bad, of course. They do lots of good for us. But the bad thing is that we've been poor stewards of the chemical revolution. We've done a bad job of testing the chemicals, and the result is that 75 or 80% of the chemicals to which we and our kids are exposed every day have never been tested for toxicity. So these factors, rising rates of disease, changing environment, widespread exposure to untested synthetic chemicals, these are the factors that set the context in which we created the Children's Environmental Health Center a decade ago, and this is the space in which we work today. And all of that is heightened by the recognition that children are uniquely vulnerable to chemicals. The human fetus, the infant, the young child is much more vulnerable to toxic chemicals than we adults. The fact that they're growing and developing and their organs are forming, all those wondrous processes create enormous vulnerabilities. And if a child is exposed at the wrong moment in early development to lead or to a pesticide or to a plastics chemical, the consequences can be one or another type of developmental damage. So here's some of the data. There's a strong and growing body of science that connects environmental exposures to disease. I mentioned air pollution and asthma. This is a classic study that came out of University of Southern California a decade ago, linking outdoor air pollution to asthma, and there have been numerous studies since that time. The Harvard Six Cities study is another classic. Then with regard to childhood causes of cancer, we know that benzene, which is a widely used solvent, is a potent cause of leukemia. And then the bottom article down there is one that we published just last year from our center, looking at toxic chemicals that are widely used in consumer products and linking these chemicals to neurodevelopmental disorders in children. I'll conclude my opening remarks by making the final big point that I want to convey to you, and that's the notion that diseases caused by toxic chemicals in the environment can be prevented. They're not inevitable. They're not like earthquakes or lightning. These are diseases that are the consequence of children's exposure to chemicals that were produced by humans, and so if we change methods of production, if we control patterns of exposure, if we properly test chemicals before kids are exposed to them, that combination of factors can reduce exposures and prevent disease. And one classic example that took place a quarter century ago in this country is the removal of lead from gasoline. Back in the 1970s, we used to use more than 100,000 tons of lead in gasoline every year. Those of you of my age will recall that lead was added to gasoline to increase engine performance, and it went through the engine, came out the tailpipe, it polluted the landscape, and it got into children. And back then, children's blood lead levels were 20 times higher on average than they are today, except at the time we thought it was normal because that's the way every child was. We were blind to the consequences. And then in the 70s, we began to learn that ubiquitous lead was actually reducing children's intelligence, shortening their attention span, altering their behavior, and we prevailed upon the U.S. Environmental Protection Agency to take lead out of gasoline and also to take it out of paint. And the consequence was that as the gasoline lead came down, which is the red line there, the blood lead level in the yellow line also plummeted in the 4 years between, in the 5 years between 1975 and 1980. And that's a trend that's continued downward since that time. So the blood lead levels in American children have now fallen more than 90% since the 1970s, with extraordinary results for children's health and the health of this country. So that 90% drop in blood lead levels resulted in a great decrease in childhood lead poisoning because kids weren't exposed. It also resulted in an increase in the average IQ of American children born since 1980. It's been calculated that population IQ has increased somewhere between 2 points and 5 points across the entire population. And thirdly, a third consequence of this has been economic. Pediatricians aren't used to thinking in terms of economics, but it's helpful to have numbers when you talk to politicians and try to get them to do the right thing. And it turns out that an IQ point is worth money. An IQ point is worth about $10,000 over a lifetime. And the notion is fairly simple. More intelligent people are more economically productive. So do the math. We have 4 million babies born in this country every year about. Give them all about 4 or 5 points of IQ as the result of taking lead out of gasoline. So that's 4 million babies times 5 IQ points, to be generous. That's 20 million IQ points added in each annual crop of babies born since 1980, and then multiply that by $10,000. And that gives you, if you're quick with arithmetic or you've done it beforehand like I did, that gives you $200 billion return to the economy each and every year since 1980 as a result of one preventive action, taking lead out of gasoline. It's really quite impressive, and even politicians get it when you put it in those terms. So maybe we can get the Congress to do the right thing. So that's why those are the reasons we do prevention. So why breast cancer? Why should a children's environmental health center be focusing on breast cancer? Well, it has to do with the growing realization that at least some of the factors that result 20, 30, 50 years later, 70 years later in breast cancer are exposures that take place very early in life. There's a growing realization today that there are what are called windows of vulnerability in very early life, during the 9 months of pregnancy, during fetal life, again at puberty when a young girl's breasts are first developing and they're going through that rapid development. Those are times of particular vulnerability. And the suspicion is growing that if the wrong exposure takes place during those moments of vulnerability, the consequence might be various diseases, breast cancer among them, years or even decades later. Some of the reasoning here is by analogy, because we now know that other adult diseases, we know quite well because really good studies have been done, linking other adult diseases to early life exposure. So for example, there's a very famous researcher in the United Kingdom named David Brca who has shown that men and women who were seriously undernourished in the UK during the war years in the 1940s, if they were seriously undernourished during the 9 months when they were in their mother's womb, that 40, 50, 60 years later, they are at seriously increased risk for diabetes, heart disease, hypertension, and kidney disease. All other things being equal, gender, age, race, economic status, etc. The fact that they were malnourished in utero substantially increases their risk for disease decades later. And we have some data from animal studies showing that early life exposure of certain laboratory animals to toxic chemicals increases risk for breast cancer. So connecting the dots, the suspicion is growing that certain exposures at the wrong moment in early life may push up the risk for breast cancer. And it's to pursue that line of research and to answer those questions that we've gathered this multidisciplinary team here today to talk with you and to present the data. So we have the three speakers besides myself. Elisa Port, whom I'll formally introduce in a moment, is a breast surgeon who's the chief of breast surgery in our Dubin Breast Center here at Mount Sinai. Then Susan Teitelbaum, who's an epidemiologist in the Department of Preventive Medicine, and then my colleague, Dr. Bob Wright, who's the vice chair of our Department of Preventive Medicine and deputy director of the Children's Environmental Health Center. So what we're going to do is we're going to do the two talks, Dr. Port followed by Dr. Teitelbaum, and then the four of us will come up to the table here and we'll do the Q&A. To handle the logistics on the questions and answers, you will find little white 3x5 cards in your folders. Hopefully you all got a folder when you checked in at the front desk. Please write you don't have to identify yourself, you can if you want to. We always like to know who you are, but you can be anonymous, that's okay. Write your question on the 3x5 card, and there'll be staff on the side aisles who will take your questions and pass them up to us. And that we've learned from experience that it makes it go more smoothly and effectively instead of having people ask the questions from the floor. All right, so that's the plan of the day. Coffee's outside, restrooms are nearby, and make yourselves comfortable and welcome to Mount Sinai. The next speaker is Dr. Elisa Port. Elisa is as I said, is a renowned breast surgeon. She is a pioneer in what's called sentinel node biopsy, a procedure to make early diagnosis of breast cancer to get the best possible result by doing early diagnosis. She's also an acclaimed researcher. She's published in major journals. She has grant funding from the Susan B. Komen Foundation, and she's currently engaged in a couple of clinical trials to test inhibition of various metabolic enzymes as a therapeutic strategy for treating breast cancer. So, Elisa, we're delighted to have you here. Thank you very much.
Good morning, and thank you so much for the introduction. I am going to leave it to the environmental experts to talk to you in more detail about some of the potential connections between environmental agents and breast cancer. But really what my role is to kick this off, is to give you the lay of the land relative to breast cancer from those of us who are in the trenches taking care of people with breast cancer every day. We do have some identifiable risk factors related to the causes of breast cancer that we know to be true. Making those connections to the environment are obviously critically important because, as Dr. Landrigan said in his introduction, these are potential interventions to reduce the risk of getting breast cancer, either in our women at increased risk or obviously their offspring. So again, just to start to give you the lay of the land, what is the scope of this problem? Breast cancer is the most common solid malignancy to affect women in the United States. We had approximately 300,000 new cases diagnosed in 2014. Of course, it's important to know, incidentally, that breast cancer can affect men. Less than 1% of all breast cancer cases affect men, and it's less than 1% of all the cases of male cancer, but it's still roughly about 2,500 cases of male breast cancer that we see in this country every year. As I mentioned, it is the most common solid malignancy, and I think one of the ways to wrap your head around the scope of this problem is to realize that almost 1 in 3 of all cancers diagnosed each year in women is a breast cancer. So it's incredibly important in the scope of oncology today. We do have reasons for optimism relative to the care and treatment of breast cancer. First, the death rate from breast cancer has been declining steadily. From 2000 to 2010, mortality from breast cancer declined almost 2% per year. And so what that means in 2015 and for 2015 is that the survival from breast cancer has never been better, and for all patients grouped together, it now approaches almost 90%, which is significantly higher than from the 70s and 80s when survival from breast cancer overall was closer to 70%. What are the reasons that we think we've made this progress, and what do we attribute it to? The first is treatment options are better. We have different targeted chemotherapies, different options for hormonal treatment that absolutely reduce the risk of breast cancer recurrence, improve survival, and lead to overall improved survival rates among patients with breast cancer. The second factor on the flip side of this is earlier detection. Mammograms really started to take off in the 80s and became more prevalent, its use in the 90s, and this led to detection of breast cancers that were smaller and therefore more treatable and more curable. So this combination over the last 20 or 30 years, increased options for treatment and improved earlier detection has led to dramatic improvement overall in the survival of breast cancer. It's important to know when we're talking about, again, the lay of the land, that breast cancer still is most commonly a disease of elderly women. If you look at this age distribution curve, about 75% of all cases are in women over the age of 50. And the average age of a woman diagnosed with breast cancer in the United States is 61. But there are other risk factors that can affect a woman's risk of getting breast cancer and their risk of getting breast cancer earlier. And we'll go through those individually to give you a clearer sense of who's at risk. Well, first of all, who's at risk? Having a personal history of breast cancer is really one of the leading risk factors of getting a breast cancer again. That being said, the risk of getting a second breast cancer is often overestimated by those who have it. So for example, for a woman who's had breast cancer on one side, and these are the people that I see every day, newly diagnosed with breast cancer, if you ask that person what they perceive their risk is of getting a second cancer, for example, in the other breast down the line, they will often throw around numbers upwards of 20%, 30%, even 50%. The truth of the matter is that in the absence of a genetic predisposition, a woman's risk of getting a new cancer on the other side is less than 0.5% per year, or putting that more simply, less than 5% over the ensuing 10 years. So dramatically lower than what one might expect. Similarly, for a woman diagnosed with breast cancer, their risk of recurrence in that breast after a lumpectomy and radiation, which is the standard treatment, is less than 5% as well. So while we do recognize that women with a personal history of breast cancer are those who are at the highest risk, who need to be monitored the closest, their risk is still acceptably low. Well, what are the other risk factors related to breast cancer? We know, and everyone's familiar with the fact that having a family history of breast cancer puts you at increased risk. But what's important to know is that the degree of increased risk ranges significantly from minimally higher to exceedingly high. And this, too, is also often overestimated among the lay population. So, for example, if a grandmother had breast cancer at age 87, really late in life, this probably does not affect an individual's risk of getting breast cancer herself too dramatically. And for this type of scenario, we really wouldn't change screening recommendations for this particular person in terms of being more vigilant. However, if you take a person who's got relatives who were young at the age of diagnosis, premenopausally particularly, we also factor in the number of relatives diagnosed. Having two sisters diagnosed as opposed to a grandmother or a second cousin once removed is really significant. And also, again, the closeness of that relationship. So when we are seeing a patient who we feel is, or she feels is at risk for breast cancer, these are the factors related to family history that we have to tease apart and get down to a granular level to really give someone an idea of what their risk of breast cancer is based on their own personal family history. For sure, there is the perception that family history and having a family history accounts for the vast majority of breast cancer risk. But really, this is a misconception and one that's worth clarifying. Believe it or not, 80 to 90% of women diagnosed with breast cancer in the United States has no family history. They are their family history. So not having a family history, importantly, does not let you off the hook. Having the family history does increase your risk. Not having a family history does not mean one is not at risk. And this is really critically important. We see patients all the time coming in saying, well, I didn't get a mammogram at age 40, as is supposed to be recommended, because I thought I wasn't really at any increased risk because of the fact that I have no family history. Well, having a mammogram at age 40 is the recommendation for the general population. So it's important to clarify this whole concept of family history and what that means relative to the general population. There are other risk factors that increase one's risk of getting breast cancer. Over the course of a lifetime, many women, either through a mammogram or an ultrasound, have identified abnormalities. These abnormalities can lead to biopsies. And when we do these biopsies, most women are under the impression that there are only two possible results, normal and cancer. There's two buckets. That's actually not true. There's actually three categories. There's normal, there's cancer, and then there's what I call in between. In between is not cancer, but in between means we see some changes in the cells that indicate that there is a higher likelihood of further changes in the future. And these changes do mean that the woman is at slightly higher risk of developing breast cancer in the future. So, for example, atypical hyperplasia is an example of one of these changes that you can see in the cells. When a woman has atypical hyperplasia, her risk of getting breast cancer over her lifetime is bumped up to about 15% over her lifetime. Not dramatically higher, but a little bit higher than the average woman's risk, which is about 10%. LCIS, which stands for lobular carcinoma in situ, and you try talking to a woman in your office and convincing her that something with the name carcinoma in it is not cancer, but it's not. LCIS, again, is a marker for an increased risk of getting breast cancer in the future, and that risk is about 20%. So we see patients all the time and counsel them regarding their risk of breast cancer related to these two cellular abnormalities that are associated with increased risk of breast cancer. And then, as Dr. Landrigan mentioned, there are other hormonally related factors. Breast cancer is very much a hormonally connected cancer. And there are all this constellation of hormonally related factors that may or may not be influenced by the environment that are associated with an increased risk of breast cancer, albeit marginal in many cases. So, for example, the age at menarche, women who develop their periods at a younger age are at increased risk for breast cancer. The number of pregnancies, the more pregnancies, and the younger you are when you start having babies, the lower the risk. One of the things that we know, for example, from demographic data, certainly in New York City, is women are having babies later and later in life. And that has been pointed to as one of the potential attributors, or one of the potential contributors, I should say, to an increased risk of breast cancer. It's known that breastfeeding does reduce the risk of breast cancer, again, by a very marginal factor. And certainly hormone replacement therapy, which is usually done postmenopausally, can increase one's risk of breast cancer. And so I think you'll hear more from the subsequent speakers regarding how environmental factors might play in to these hormonal factors, some of which are controllable, like hormone replacement therapy, and some of which may not be relative to age at menarche unless there are other environmental factors playing into this. And then it gets a little bit trickier. You know, most women do not live their lives in a vacuum, so we have plenty of people who come in, for example, who want to be watched more closely because they do have a family history of breast cancer, and then something comes up on a mammogram and they're diagnosed with atypical cells. And the question always comes up is when you have a combination of risk factors, are they overlapping or are they additive? Do you take a family history of breast cancer that's associated with a 20% risk and a history of atypia that's associated with a 15% risk and put that woman in the 35% risk category? And most of the data suggests that no, it's overlapping. And so you take the most prominent risk factor and that becomes a surrogate for everything else. But again, this is really a source of controversy in terms of assessing risk. One of the things we do know is that there are a couple of categories that put women at the highest risk for breast cancer, and these are now identifiable and actionable. You have to be living under a rock to not know about BRCA1 and BRCA2 in the last couple of years, and we'll talk about the reasons why for that in a minute. BRCA1 and BRCA2 are two breast cancer genes, but it's important to know we all have these genes, okay? What happens is that we're each born with two functioning copies of the gene, one from our mother and one from our father. And you have to think of this as sort of a backup plan. So if one of the genes misfires or becomes malfunctioned, the other gene backs it up in that cell and continues to work, okay? In 1 to 2 of 1,000 people in the general population, or less than 0.1%, one copy of this gene is inherited as mutated. And that means that it's non-functioning in every cell in the body. And so what that means is that people who have this mutated gene are walking around with no backup plan. Okay, so they have one functioning copy and one mutated copy. And obviously these people are at the highest risk that if something happens to that one functioning copy, they're left with no functioning copy of this gene, and that's when cancers arise. Interestingly, from a demographic standpoint, as we know, certain diseases for genetic reasons and for procreation reasons tend to cluster in different ethnicities. And in the Ashkenazi Jewish population, there is a much higher incidence of the BRCA1 and BRCA2 mutations. And so among Ashkenazi Jews, it's as high as 1 in 40 rather than 1 in 1,000, and almost 2%. And this has led to some groups advocating testing in the entire Ashkenazi Jewish population. Important, what are the implications of having a BRCA mutation? Well, first and foremost, we already talked about the fact that in the general population, the average age of diagnosis of breast cancer is about 61. When you have a BRCA mutation and a genetic predisposition to breast cancer, the likelihood of getting breast cancer at an earlier age is much higher, 40, and so this has obviously serious implications for screening and when to start screening in this population. BRCA is associated with an 80 to 90% lifetime risk of getting breast cancer and about a 20 to 40% risk of getting ovarian cancer over one's lifetime. There's also an increased risk of other cancers associated with BRCA mutations, such as prostate cancer in men, pancreatic cancer in men or women, and male breast cancer is associated with the BRCA2 mutation, leaving men with about a 10% risk. It's really important to know, for those of us who are clinicians, that BRCA1 is associated with a more aggressive tumor type in general. About 75% of all of the tumors that BRCA1 leads to are what are called triple negative, meaning they're not hormonally responsive, they don't respond to some of the targeted agents we have, and they're therefore more difficult to treat. If you compare that to the overall percentage of triple negative breast cancers in the general population, it's about 10 to 15%. Again, also associated with BRCA1 is a higher risk of ovarian cancer, approaching 20 to 40%, as I mentioned. BRCA2, on the other hand, the tumors are a little bit more indolent. They're ER positive normally and hormonally receptive. The risk of ovarian cancer is lower, 10 to 20%. And the age at which women develop ovarian cancer, while it's closer to 40 when we start worrying about it in BRCA1 and BRCA2, it's felt to be a little bit older. And so it gives women perhaps a little bit more wiggle room relative to the prevention of ovarian cancer by choosing to remove their ovaries and the timing of that. Well, who's at risk for having a BRCA mutation? And we'll talk a little bit in a minute about the incredible amounts of publicity this gene has gotten in the last couple of years. But it is important to know that among the general population, it is very rare. And so calls to get everyone tested are probably ill-conceived. But there are definitely red flag situations in a family where we should be targeting these women for screening. First red flag, any family where there are 2 first-degree relatives with premenopausal breast cancer. So if I had breast cancer at age 45 and my sister had breast cancer at age 42, that would be a situation where we may want to ask our doctors about getting tested. Any combined family history of breast and ovarian cancer is a red flag for a BRCA mutation. Any history of male breast cancer, that person should consider BRCA testing. Any personal history of breast cancer under age 40. And so in my office, any woman that comes in who's been diagnosed with breast cancer before age 40, regardless of her family history, gets tested. And any personal history of breast cancer under age 50 in an Ashkenazi Jewish person. And then there are, of course, what we call the extenuating circumstances. And we as clinicians have to be a little bit more of detectives before we decide to tell someone, no, they don't need to be tested, or yes, they do. You have these very difficult situations where what if someone comes in, for example, the most obvious, that is diagnosed with breast cancer and they're adopted and they have no idea of what their biologic family history is, and make believe they're 42. So they don't fit into any of the conventional criteria, but you really have to say this person's family history is a black box, not only for breast cancer, but for many other diseases as well. And do we want to be more aggressive about finding out any information we can about this person? Similarly, I have patients who come in all the time and say to me, I don't have any family history of breast cancer, but there have been really few women in my family. My mother died at a young age of, in a car accident. My father only has brothers, and I'm an only child. And so you have to really look long and hard at these family histories and really take on a case-by-case basis whether or not you want to send these people for genetic testing. When someone is diagnosed with a BRCA mutation, and we now know that they're at highest risk for developing breast or ovarian cancer, what are the options? Well, option number 1 is, of course, watching and waiting, screening and surveillance. And again, with these women who are at the highest risk of getting breast cancer and getting it at an early age, we kind of, forgive the expression, but throw the kitchen sink at them. They do get yearly mammograms, usually starting at age 25, and they do get yearly MRIs, which has been shown to pick up cancers that mammograms miss, again, starting at age 25. And normally what we do is we do mammograms once a year, for example, every January, and MRIs once a year, say every July. So they are getting tested twice a year. And this is coupled with 2 to 4 times yearly physical exams so that if God forbid they develop what's called an interval cancer in between, we can have the highest chance of picking that up. In this group of women, screening can be performed until something develops. But understand that when people are aggressively screened, the more you look, the more you find. And this is going to lead to high levels of anxiety for our patients, waiting for the other shoe to drop, lots of exams, and certainly at some point biopsies that may or may not show anything. So women have to be prepared on this path that it is going to be an arduous course associated with significant amounts of stress and anxiety. Most importantly, when women choose this path, is they have to know what they get and what they don't get. What they get is a very high likelihood that if they develop something, it will be detected early. But what I tell my patients, and I know this sounds kind of used car salesman-ish, is early detection is a goal, it's not a guarantee. And it's incredibly devastating and humbling to all of us when 1 month after a normal MRI, a woman comes into our office and says, "What the heck is this?" And it ends up being a cancer. And that is just the nature of BRCA, that early detection is not prevention. So also important to know is that every cancer diagnosis is associated with some risk of mortality. So the minute something shows up on an exam and it's proven to be a cancer, that ship has sailed. And we're no longer talking about prevention, we're talking about attempting to cure a cancer. Importantly, BRCA1 is associated, as I mentioned, with some of the more aggressive breast cancers. So sometimes even the earliest cancers can be associated with a risk of mortality again and the need for aggressive treatment. So all of my patients who are diagnosed with BRCA, a BRCA mutation, have to hear this conversation to understand what they get and what they don't get when they choose the path of watchful waiting. What are the other alternatives for these patients? If they don't want the watchful waiting for the other shoe to drop path, what are the options for prevention? Well, sadly, there aren't many. And really the only effective option for breast cancer prevention in women with a BRCA mutation is what we call risk-reducing mastectomy. We've shied away from using the term prophylactic mastectomy, which means prevention, because cancer still can develop after this operation, although the risk is incredibly rare when the surgery is performed correctly and all the breast tissue is removed. So what does risk-reducing mastectomy do? It removes breast tissue to reduce the tissue at risk. Again, it's not completely preventive, but it is highly effective. When performed effectively, can reduce the risk of a woman getting breast cancer from that 80 to 90% to less than 1 to 2%. So really, really efficacious. In the last 5 to 10 years, there has been increasing interest in this path because thankfully options from reconstruction have improved so dramatically that the cosmetic results are not nearly as disfiguring as they were in generations past. So to give you an example, this is a patient, and if you look at the top two panels, this is a patient who underwent bilateral risk-reducing mastectomy, and here's her before pictures up top. And you can see down below, we did a nipple-sparing mastectomy, and you can see this is about 2 months post-op. She still has some scarring, but in general, overall, the risks are what most people would consider very, very acceptable relative to cosmetic results. And the ability to wear almost anything you want, including a bathing suit. And so as a result of this kind of result, which is not the exception, this is a kind of the norm, obviously depending significantly on what kind of body habitus a woman starts with, this is definitely increased interest levels. And of course, the biggest boon to risk-reducing mastectomy came last about a year and a half ago when Angelina Jolie, and obviously there have been other celebrities who preceded her, but one of the most well-known women opted and went public with her desire to reduce her risk of breast cancer in the setting of a BRCA mutation, and indicated in the New York Times, "I can now tell my children that they don't need to fear they will lose me to cancer." This was in 2013. So this led to many, many people, BRCA coming to the forefront of many people's consciousness. And also we got lots of phone calls after this saying, I was on the fence about doing this, I think I'm ready now. And knowing that I'm a BRCA mutation carrier. Well, one of the really, really interesting sequelae from the whole Angelina Jolie story was that, of course, when something happens to a celebrity, everyone reads about this, and the first thing they ask themselves is, well, what does this mean for me, if anything? And the truth is that given the rarity of the BRCA mutation in the general population, the stock answer is probably nothing. However, last year, the Canadians did a very interesting study that showed us something very interesting. And what did they show us? That they compared the number of BRCA testing referrals in the 6 months prior to Angelina Jolie's announcement to the 6 months after. And there was a 100% increase in testing referrals for BRCA testing. So normally we would dismiss that and say, yeah, that's just the public becoming hysterical over a celebrity having something that doesn't really apply to them. Except for one thing, and that is, guess what? There was a 100% increase also in the actual detection of mutation carriers. And so what that means is not only was it hysteria, but there were actually people who were self-referring or whose doctors became more aware, and more actual mutation carriers were being detected. And so to me, the take-home message for this is, yes, while it's going to generate hysteria among different groups of people, awareness is always a good thing, and really can't be a bad thing in any way. I think what it also showed us is that women do have to be their own advocates, because among things like BRCA mutation carriers and risk for BRCA mutation, there is a substantial knowledge-based deficit even among general healthcare providers regarding BRCA and who's at risk. So for example, there are many doctors who do not realize that BRCA can be handed down on from both the mother and the father's side of the family. And so it's really critically important when you're assessing risk for breast cancer, you ask about the father's side too. And many healthcare providers say, your father had a sister who was diagnosed with breast cancer at age 50. That really doesn't put you at increased risk at all. That's a second-degree relative. And so these are really, really important factors to tease apart. And so I think that's what this study showed us. And again, it's important to be proactive. Just a note on BRCA and the ovaries. The ovarian cancer risk for associated with BRCA is dramatically lower than that seen with breast cancer. It's 20 to 40%. However, and we screen for ovarian cancer with a CA-125 blood level and a pelvic ultrasound. However, these tests are known to be highly ineffective for picking up ovarian cancer at its earliest stages. Believe it or not, about 50% of women with stage 1 ovarian cancer have normal CA-125 levels. So as I like to say to women, there is no mammogram or MRI for early detection for the ovaries. There is no equivalent. And that's why when women develop ovarian cancer, it's usually stage 3 or stage 4. And that's why we're much more aggressive about recommending having the ovaries actually removed, typically on or about age 40 or even slightly before for BRCA1, and around age 40 or perhaps a little later for BRCA2. It's really around age 40 that the risk of ovarian cancer starts to accelerate. Recent studies have shown perhaps a little bit earlier for BRCA1. And fortunately, it does give most women a window for childbearing before having to consider removing their ovaries preventatively. Another of the groups, I mentioned that there are really two groups at the highest risk for breast cancer, and I talked about the BRCA population, and this, I think it's important to mention this group because this can factor into heavily in terms of the subsequent talks regarding environmental exposure. We know there is a second smaller group that are at extremely high risk for developing breast cancer, and that is those who underwent chest wall radiation. Chest wall radiation absolutely increases the risk of breast cancer significantly, And the most common reason to need chest wall radiation is Hodgkin's disease, which has what we call a bimodal distribution, meaning it's very common in the younger ages, like 15 to 25. There are people who get it in their 20s, 30s, and 40s, but then again, it happens later in life in the 50s and 60s and so forth. But the radiation that needs to be given for Hodgkin's disease, what's called mantle radiation, during the formative years of breast tissue, in the 15 to 20 age group specifically, can increase a woman's risk of getting breast cancer by a factor of 40. So she's 40 times higher than the average woman of getting breast cancer in the future. Interestingly, the diagnosis of breast cancer can be seen as early as 8 years after treatment. And so as a result of that, screening must start very early. And we take this hugely into account when we're seeing women at increased risk. The risk of breast cancer for those diagnosed with Hodgkin's disease later and who receive the mantle radiation later in life, meaning in their 40s, 50s, and 60s, after the breasts are fully formed, is not quite as high, clearly, than those who get it younger. And this factors into the whole conversation that's going to go on later regarding the age of exposure and the significance of that. Quickly, lifestyle factors. Many lifestyle factors and environmental factors have been thought by the general public to contribute to breast cancer risk. Here's what we know. Alcohol definitely increases the risk of breast cancer and probably increases the risk of breast cancer recurrence in those who have breast cancer. What does heavy alcohol intake mean? The increased risk is usually starts at around 1 drink per day every day. So more than 1 to 2 drinks a day every day can increase the risk of breast cancer. We think this is because we know alcohol is metabolized by the liver, and the liver also breaks down circulating hormones. So probably the liver dysfunction related to heavy alcohol intake results in decreased hormone metabolism, and therefore the hormones can't be metabolized as well. What we counsel our patients who have been diagnosed with breast cancer, who are at increased risk for breast cancer, is to take alcohol in moderation. One drink a day every day is probably too much. 3 to 5 drinks a week is what's considered moderation. And the second factor, which is absolutely gaining in momentum and factors into all of the environmental factors that will be spoken about and have already been touched upon, is obesity. There is no question that obesity increases the risk for breast cancer and increases the risk of recurrence. And the mechanism for this is probably most likely related to peripheral estrogen production in fat stores. We know the ovaries are the primary source of estrogen production, but fat stores produce estrogen as well. And so this is kind of throwing fuel on the fire. Interestingly, until recently, there was really only data for this in the postmenopausal population, but more recently it's been suggested in the premenopausal population as well. So while my personal feeling is it's very sadistic to tell someone diagnosed with breast cancer when they're most stressed out, now you got to lose weight too. And we try not to do that. We do try and make it a long-term goal after the diagnosis of breast cancer, when they're done with treatment, to address weight concerns. And at the Dubin Center, we actually have a full-time nutritionist on staff and absolutely refer all of our patients with unhealthy or BMIs consistent with obesity to our nutritionist for counseling to start tackling this issue. My personal feeling is that not discussing obesity with a woman diagnosed with breast cancer is really tantamount to not discussing smoking cessation with someone who's been diagnosed with lung cancer. Women always want to know what they can do to reduce their risk, and this is one of those factors. It's a difficult one to tackle, though, for any patients. So in the end, despite all these known risk factors for most women, there are no identifiable or known risk factors. So again, looping back, we talked about the fact that most women don't have a family history. Most women don't have atypia. Most women don't have LCIS. And that leaves us with the idea that for most women diagnosed, they don't have any of these identifiable risk factors we just discussed. Family history, pathologic things, lifestyle factors. And so where does that leave us for 80 to 90% of women with no identifiable risk factors? I don't know if any of you guys read the New York Times or Science about a week ago. The recent theories are that 2/3 of cancers are due to what we call bad luck, otherwise known as mutations in rapidly dividing cells. Well, one of the things that I think figures prominently into this conversation today is there anything that's speeding up or leading to these mutations happening environmentally? And so far, nothing has been clearly identified in a cause-effect kind of fashion. And I think we'll hear more about that in the later talks. So in summary, breast cancer is predominantly a disease of aging. Family history does increase the risk to varying degrees, as do other factors, but most women do not have a family history of breast cancer, and so they're not off the hook. BRCA positivity and chest wall radiation are associated with the highest risks of breast cancer, and those women need to be watched closely, and we even consider making preemptive strikes in those patients in the form of risk-reducing surgery. The modifiable lifestyle risk factors that we discussed are alcohol intake and obesity. These are modifiable risk factors that a woman can use to reduce her risk of getting breast cancer or reduce her risk of recurrence if she already has breast cancer. But importantly, the message I want to leave you with is that all women, and of course a few men, are at risk even with no identifiable known risk factors. So awareness and appropriate screening are critical for early detection and appropriate for all women. Thank you.
Thank you, Elisa. We'll hold the questions. We'll have our second talk, and then, as I said at the beginning, we'll do the questions and answers in the form of the panel. And let me remind you, for those of you who came in, that we won't be taking verbal questions from the floor, but there's a 3x5 card in your folder, and please write your question on the card and pass it to one of the staff, and we'll bring them up to the front. Okay, so our second speaker this morning is Dr. Susan Teitelbaum. Susan is an associate professor of epidemiology in our Department of Preventive Medicine. She got her PhD from Columbia University, Mailman School of Public Health. She's been a member of our faculty for a decade.
Yeah.
Time flies. And has done a great deal of work on environmental factors, the urban environment, diet and health, and breast cancer epidemiology. She's also done a great deal of collaboration with the breast cancer activist community here in New York State, and it's a delight to have you here, Susan.
So thank you, and I'm really honored to be here, talk to you a little bit about one of the big areas of my research program, which is the environment in breast cancer. So the dictionary defines environment as the complex of physical, chemical, and biotic factors that act upon an organism. And when we think about the environment, we may picture a beautiful landscape with lovely trees and clear, clean water. However, this is only one view. And then there's us city folks, and we live in a different environment, and this is, to some people, very beautiful, just as beautiful as the trees, but it's different, and the exposures that we may get from this environment may differ as well. So when we think about the environment with respect to breast cancer, we look at hazardous environmental exposures that we may encounter, and these may come from numerous sources. And these types of exposures include contaminants from industry and manufacturing, they're contaminants from agricultural sources like pesticides, and there's environmental exposures related to our modern lifestyle. And, automobile and plane travel, dry cleaning, drinkable tap water, electricity, cellular communication, these are all things that make our life absolutely wonderful, but they also do involve exposures that we end up encountering. And so many of these byproducts of our modern life end up in detrimental environmental exposures. Examples like trihalomethanes that increase cancer risk that are byproducts of water disinfection. But clean water is really important. Household pest control. You want to keep those bugs away from your home, but they end up being a component of carpet dust. And then children walk around on the carpets or crawl around on the carpets and they get exposed to the dust that may have the pesticides. So these are all things that we have to think about. And my job as an environmental epidemiologist is try to examine this complex mixture of exposures. And first I want to identify which of these exposures may be detrimental or toxic to health. And then I want to, as my second approach, take a study and look at the relationship between these exposures and how they may be associated with breast cancer. And we've identified a lot, and Dr. Landrigan told you about the number of new chemicals that are being identified every year. And the question is whether or not they have the potential to affect a woman's probability of developing breast cancer. But as you'll see, all these chemicals, a lot of them, the epidemiologic evidence for their exposures is still being sought. So in 2003, a study was conducted in 120 homes in Cape Cod, Massachusetts, where measurable concentrations of dozens of toxic chemicals were found in indoor air and dust. And a reporter from the LA Times called me and wanted to know what I thought about this paper. And I said a lot of things about the importance of the information that the study provided us with and how it's critical to understand the complexity of the exposures that we're all experiencing. Yet the reporter chose this quote: "We're living in a soup." And I was like, great, I'm going to be remembered for calling the environment a bowl of soup. But actually, take a step back and think about it, and soup is actually quite a nice metaphor for the environment. When you eat soup, you can taste and see a lot of the ingredients, and you can identify them. A lot of times, you eat soup and you think, there may be something in here. I can't quite figure out what it is. And there's a lot of times in soup, there are things that you have no idea are in the soup, and you're eating the soup. So truthfully, the environment is really a soup, and it did work as a good metaphor. I wasn't happy about the quote, but that's life. And so another thing you want to think about soup, this is just to give you my epi perspective, the proportions. Every recipe for soup is different. And so the proportions of the ingredients in soup, although they may be identical, may not be the same. So you've got different levels of exposure in the environment. And so all of these concepts are things that we deal with when we're trying to look at the role of the environment in the development of breast cancer. So, as I said, the environment is complex, and environmental exposures have been explored with respect to cancer in general as well as breast cancer. And when we're identifying these exposures, we look for biological properties that make them likely candidates for breast cancer risk factors. This might include that the chemical exposure has cancer-causing properties, or it can cause damage to DNA, or it could have hormonal properties. And in some cases, exposures may have more than one of these properties. And this list that I have up here is growing, and all of these have been investigated with cancer, and many have been investigated with respect to breast cancer. And time's not going to let me give you a rundown on every single one of these exposures, but what I'm going to do is give you a short background on a selected set of these exposures to give you an idea of how we've been studying the environment in breast cancer, what we know, and what we don't yet know. So it was a perfect lead-in from Dr. Port's presentation. Ionizing radiation is one of the most well-known environmental risk factors for breast cancer. And it's an invisible high-frequency radiation that can damage DNA. And we have all been studying radiation with respect to cancer for a very long time. But it's clearly linked to breast cancer. And one of the most convincing pieces of evidence is the study that was conducted on atomic bomb survivors. And what was found was it really depended on when a woman was exposed to the radiation from the atomic bomb explosion with respect to her risk of developing breast cancer later in life. And from this graph, what we see is that the women who were exposed at the youngest ages, less than 10 years old, were at a much greater risk of developing breast cancer than women who were 50 to 60 years old when they were exposed. And it was a very clear trend of decreasing risk as you got older at the time of exposure. And what it shows us that not only is it sort of leads us into what Dr. Landrigan was talking about, windows of susceptibility, that at different ages, exposures may have very different properties with respect to the future development of breast cancer. So, another type of radiation is electromagnetic fields, and they're produced by electric transmissions and distribution lines, electrical appliances such as air conditioners, microwave ovens, heaters, refrigerators, televisions, computers, and they're even generated by the Earth and in the atmosphere. And scientists have hypothesized that exposure to EMF may increase estrogen levels, and as Dr. pointed out, breast cancer is a hormonally related disease. So the hypothesis works that melatonin is suppressed by electromagnetic fields, but melatonin inhibits estrogen production. So if you're decreasing melatonin because of higher exposure to EMF, you actually may be increasing exposure to estrogen. And that's the underlying concept for why EMF has been studied with respect to breast cancer. So there's two types of studies that have really explored this exposure. One is occupational, because there are many occupations where exposure to EMF is generally higher than in the general population. This includes people who work in electronics and electrical manufacturing industries, being a telephone installer, being a repair person who does electrical repairs, are all examples of occupations that are likely to have higher EMF exposures. And although women are less represented in these industries and occupations, they are represented, and studies have been conducted on this occupational exposure. And the results of these studies have shown that EMF exposure leads to an increased risk of breast cancer. They've also studied EMF as a residential exposure by measuring electromagnetic fields within homes. But these studies have been rather inconsistent, and it was unclear from the sort of general population level exposure whether or not EMF is associated with breast cancer. However, recently, a meta-analysis was performed on 23 case control studies of EMF and breast cancer. And a meta-analysis is when the studies that have been conducted are all taken together and considered as one, so that a pooled or a summary result of the association can be derived from the information that was provided in each of the studies. And from the results of this study, what they saw was that there does seem to be increased risk associated with increasing exposure to EMF, but it's especially important among premenopausal women and breast cancer that are ER positive. But most of these studies did have problems with assessing or defining EMF. There was not a lot of consistency among the studies with respect to the exposure. So the recommendation, and you'll hear this a lot from epidemiologists, more studies are needed. So, on to another environmental exposure, polycyclic aromatic hydrocarbons. People may not have heard them about as much as some of the others I'll talk about, but PAHs we're exposed to them everywhere. They are the product of combustion. And so we're exposed to PAHs from burning wood and fuel for homes. They're contained in gasoline and diesel exhaust. They're found in cigars and cigarette smoke. Foods that are either smoked, barbecued, or charcoal broiled contain amounts of polycyclic aromatic hydrocarbons. And these chemicals are just ubiquitous in the environment, and we're exposed to them every day. So they've been shown to cause mammary tumors in animal studies, and they are stored in fat tissue, and they have been measured in breast tissue. So the PAH binds to DNA and it creates what's called a PAH DNA adduct. And those are measurable both in breast tissue and in blood. And so many studies have looked at in relation to various cancers, and they've been associated with lung, skin, and urinary cancer. A few studies have looked at them with respect to breast cancer, and there seems to be an indication that women at the highest levels of exposure are at an increased risk of breast cancer. But there did not seem to be a dose response in the sense that as you went up the ladder of exposure that you saw an increased risk. It was only among the women who were in the highest groups. But sometimes measuring an exposure directly may not tell you a story, but if you look at the source of the exposure in relation to breast cancer risk, you may get a better idea. And so recently, we published a study looking at use of indoor stoves and fireplaces as a source of exposure to PAHs in relation to breast cancer. And what we found was that there was no association when women reported having used wood logs in their fireplaces or indoor stoves. But when they used synthetic logs, there was an increased risk, a 40% increased risk in breast cancer. And so this was interesting, and we looked into the synthetic logs, and it turns out that when testing was done, synthetic logs produced far more PAHs than burning wood logs. And so it seems that the synthetic logs themselves may actually be a source of PAH, which may account for the increased risk that we observed in this study. So, and it also suggests that as a preventive measure, as both Dr. Porter and Dr. Landrigan pointed out, that the use of wood in indoor stoves and fireplaces rather than synthetic logs may be a way that people can reduce their exposure to PAHs. So now we'll move on to something that I'm sure everybody has heard of, DDT. And it's a member of the organochlorine pesticide family and one of the most studied environmental exposures to, in relation to breast cancer. And so the insecticide became widely used starting in the late 1940s, and it was highly effective against mosquitoes, which lead to insect-borne human disease. And additionally, it was used with great effect for insect control in agriculture and in residential use. So the problem was that as DDT was used more frequently, insects became resistant to it. And so then they had to use more DDT in order to get effectiveness. And interestingly, Rachel Carson wrote a book called Silent Spring, which many of you I'm sure have heard of, and she highlighted the effect of DDT on wildlife because in the food chain, DDT was doing a number on wildlife with respect to many different species. And in fact, her book was the lead-in to banning of organochlorine pesticides in the 1970s in the US. Today, DDT it was shown to have hormonal properties, and it is designated as a probable carcinogen. So, we actually have the honor of Mount Sinai being the first study of DDT and breast cancer. It was led by Dr. Mary Wolfe, who is a professor in our Department of Preventive Medicine. And this small study pointed to an increased risk, quite a high, an odds ratio of 3.68 with respect to women who had the highest levels of DDT compared to women who had the lowest levels with respect to their risk for breast cancer. And this landmark study spurred on many subsequent epidemiologic investigations of organochlorines. However, as more and more studies were conducted, the conclusions became less and less clear as to whether or not DDT exposure actually was associated with an increased risk of breast cancer. And one of the reasons could easily be explained as a windows of susceptibility issue, because the blood samples that were used to measure the exposure are collected close to or not too far from when the breast cancer diagnosis occurred. And they are long-term biomarkers, so it represents a lifetime exposure. However, the exposure that we're measuring now may not be representative of the detrimental exposure that occurred when a woman was much younger. And so windows of susceptibility come into play when we're studying environment, because we may only be able to measure the exposure now, and we need to extrapolate back to possibly when the exposure was more important with respect to the development of breast cancer. However, DDT is no longer being used in the US. It still is around, and it's long and persistent. And back in the 1940s, the picture on your left, which is always an amazing picture, had mosquito spraying with DDT on Jones Beach in Long Island. And the sign on the side of the truck, which you might not be able to read, said DDT, powerful pesticide, harmless to humans. And so that was, people didn't know at the time, sort of, as Dr. Landrigan pointed out with lead. It was the norm. It was used and it was effective. However, it's been banned, but something has to replace it. And so in 2002, the Times ran this picture, and it was in Mississippi. And here a truck, very similar to the same exact exposures that were being used back in the 40s. This is using pyrethroids, which is another pesticide. It's been shown to have some estrogenic properties, although much, much lower than natural estrogen. But it's considered safe because it's derived from plants. And it is a very short-acting pesticide, but in fact, it's being sprayed and used. And so here are kids playing in the fog of pyrethroids instead of DDT. Just so you know, what kind of lessons have we learned? And that kind of leads us into endocrine disruptors, because pyrethroids, as I said, have been shown to have some estrogenic properties. And endocrine disruptors go by many names. You may call them hormonally active chemicals, you call them xenoestrogens, but in fact, these chemicals that are referred to as estrogen disruptors may actually not disrupt specifically. They can act in many different ways. They can mimic and antagonize endogenous hormones. They can change the synthesis or metabolism of hormones. They can bind to estrogen or hormonal receptors. So the interesting thing about some of these chemicals are that they've actually displayed multiple hormonal properties, including estrogenic and antiestrogenic, androgenic and antiandrogenic activity. So I'm going to give you an example, because time does not allow me to give you more than one, of one endocrine disruptor that I'm sure all of you have heard about, and that is phthalates. So phthalates are actually not one chemical. They're a family of chemicals, and they are quite ubiquitous in the environment because they're used as ingredients in many, many different products. And they have function. They're not just there for no reason. Some phthalates are added for flexibility to plastic, and some are added to personal care products to stabilize fragrance, as examples. And depending on the phthalate, they've been shown to have different hormonal properties. Some have been identified with estrogen-like properties, some with anti-estrogen, and some with anti-androgen-like properties. And they've been studied with respect to a lot of different human health issues, especially in children, and they've been found to be associated with adverse male reproduction. They've been found to be associated with childhood neurodevelopment problems, and they've also been associated with increased body size in both adults and children. So, as I said, I'm going to focus on one phthalate, and personal care products happens to be a big source of exposure to diethyl phthalate. The biomarker that we measure is in the urine, and that is called monoethyl phthalate, and that's the metabolite of DEP, which is diethyl phthalate. And so we can measure a woman's exposure by asking for a urine sample and then analyzing it for phthalates, and it becomes an example of her exposure in the past. It's a short-term exposure in the past week. However, with respect to personal care products, think about it. You do pretty much the same beauty routine every day, even guys. And so the products that you're using, although the biomarker we may measure only may represent just the past week, it probably is representative of your past year if you're using the same products day in and day out. So what I want to do is just show you that this is a study that looked at, it used a case control study of women in Mexico, but only looking at the controls, so these are women without breast cancer, in order to see whether or not their reported use of personal care products was associated with their exposure to MEP. And what we saw is as the number of products increased, the reported number of products increased, we saw an increase in the urinary level of MEP, giving us support that as you use more products, you're probably being more exposed. So, going back to windows of susceptibility, one of the studies that we conduct here as a part of a consortium across the country is looking at environmental risk factors for early development of puberty. Because as Dr. Port pointed out, earlier age at menarche is a risk factor for future breast cancer risks. So we were funded to look at environment to see whether or not we could understand early risk factors for earlier development of pubertal development so that we could understand the window that's prior to the risk factor for breast cancer. And so in our first look at the data that we had been collecting, we've been following these girls. There's 1,200 girls in the study, and we've been following them since they were 6 to 8 years old, and we started in 2004. And so our first analysis, looking at phthalate urinary biomarkers, we saw that there was an association with earlier breast development associated with increased exposure to diethyl phthalate, the biomarker being MEP. And so this was early. We only had 3 years of data when we conducted this, and we have subsequently updated the study with 7 to 8 years of follow-up, and the associations remained, although they weren't as significant as they were early on. So right now there is only one published study of phthalates and breast cancer risk. This was in the Mexican case control study that I told you about previously. And in this study, they found that women who were in the highest category of the MEP exposure had twice the risk of breast cancer to women who were in the lowest category. So this, combined with the information that we know about DEP associated with earlier breast development in girls, gives us some information that phthalates may play a role in increased risk of breast cancer. Now, one of the things that you can think about, again, with respect to decreasing your exposure is quite simple, that you can change the personal care products that you use to those that are designated as phthalate-free. Now, there's no indication yet whether or not that would decrease your risk of breast cancer, but it certainly would decrease your exposure to phthalates, and that's not it can do no harm. So you can choose to consider that. So I want to give you a few take-home messages. As I told you in the beginning, the environment can be considered a soup. We know some of the ingredients in the environment, and we have an idea about some of the ingredients in the environment, and there are a lot of ingredients that we just don't know about yet. And even with the complexity, we have been able to study many different components of the environment, and we've seen some are associated with increased breast cancer. And one of the things that I want to point out is that there's an increased recognition of windows of susceptibility, and that it's important that we study exposures across the lifetime in order to get a better understanding of the role that the environment may play in breast cancer. And with respect to that, research on endocrine disruptors and breast cancer is ongoing, but the research is sparse. And as I told you, epidemiologists always say this, there's still much to be learned. So I just want to acknowledge all my research collaborators. The work that I do could not be done without them. And of course, funding from NIH and the Mount Sinai Children's Environmental Health Center. Thank you.
The person chairing the panel is going to be my colleague, Dr. Bob Wright. Bob is a pediatrician by training. He's also trained as an epidemiologist, as a geneticist, as a toxicologist, and as an emergency physician. He is now the vice chair of the Department of Preventive Medicine, the deputy director of our Children's Environmental Health Center, deeply knowledgeable about the connections between the environment and children's health. And he's sorting the cards, teeing up the questions. Feel free as the Q&A proceeds to send more questions forward. Katie Southwick over here has additional cards if you're out of cards. And without further ado, let's get started.
I actually think we're inundated with questions. I haven't been able to read them all, but obviously this is a very important topic that has generated a lot of interest, hence the very large number of questions. I apologize. I don't think we'll be able to address all of them. I think that, is Elisa? Oh. I think the speakers, will you be able to stick around for a few minutes in case individuals have questions? Okay. Dr. Teitelbaum and Landrigan, I'll try to stay as long as I can, but I'm not sure we'll be able to get to all of them. I'll try to emphasize the ones that may deal with more clinical issues. And first question is, I heard there is a higher risk to women of breast cancer in Nassau and Suffolk County. If true, is the large aquifer that services these counties and the large percentage of cesspools contributing to the public health issue?
So I'm sure many of you have heard of the Long Island Breast Cancer Study Project. And the reason that that study was actually mandated by a public law was because of the concern about the rates of breast cancer in Nassau and Suffolk counties. And in fact, so this was, the law was passed in 1993, and the Long Island Breast Cancer Study was funded in 1994, or 1994. My timeline's a little off. Anyway, I was a graduate student at the time, and I was at Columbia, and I actually ended up being the project director of the Long Island Breast Cancer Study Project, which really got me involved in the environment and breast cancer. And so the question about the aquifer was definitely one of the issues with respect to why it seemed that the environment was so important with respect to the breast cancer incidence that was occurring on Long Island, that because the water tables were high and everything that goes from the ground gets right into the water, and DDT happened to have been one of the main hypotheses of the breast cancer, of the Long Island Breast Cancer Study, was that DDT was associated with increased risk of breast cancer, was that Long Island used to be a very, very agricultural area, and there were tons and tons of potato farms, and DDT was the primary pesticide that was used on the potato farms, and so it got washed right into the aquifer, and so anybody who lived on Long Island was drinking the water, and a lot of people used well water. So the exposure, the concern was exposure to DDT. So yes, that was the reason why we were concerned. However, the rates of breast cancer on Long Island are not any higher than the rates that are the average SEER US rates. In fact, the rates of breast cancer are highest in the San Francisco Bay Area. So one of the reasons and one of the amazing things about Long Island is the breast cancer advocacy movement. And my two favorite breast cancer advocates over here that I've worked with on Long Island since I was a little graduate student and didn't have gray hair. And that was the reason why breast cancer was so important to study on Long Island, because there were people who were concerned, and they motivated the politicians to go ahead and pass the law that mandated that breast cancer and the environment be studied on Long Island and several other areas. It wasn't only Long Island, but Long Island was the one that got the most publicity. So that's the answer.
Are there links between autoimmune disease, the environment, and breast cancer?
I don't know.
Nor do I. I'm just not sure.
I can't answer that question directly, but indirectly, one of the things that I can say that's been of huge interest in our world is the concept of implants used to reconstruct breast cancer and whether or not they've increased the risks of autoimmune disease and so forth. And without answering the question directly, what I would say is, as many of you know, there was a huge kind of propaganda or public health concern about women who had had silicone implants having higher likelihood of developing autoimmune disease. And let's be crystal clear, without any kind of data whatsoever, silicone implants were taken off the market. And so for a whole generation, and this is in my lifetime, we were only doing reconstruction with saline implants without any kind of data whatsoever. When the question was studied more carefully, it was demonstrated that women who have silicone implants for reconstruction, for augmentation, there absolutely was not seen to be a higher incidence of autoimmune disease in those people. So yes, people do get fibromyalgia and they do get lupus and they do get those things, but not to a higher degree if they've had implants. And as a result of that, we saw a complete reversal, 180, in the use of silicone implants that are now back on the market and more popular than ever. And quite frankly, they do give for many patients, although we make these decisions on a case-by-case basis, they do give many patients a much better cosmetic result. So I think that it's a perfect example, kind of like the, it's interesting is the Long Island breast cancer, the question was raised, it was studied, the conclusions were made. This was really a bit of a witch hunt, and the implants went off the market before anybody could address it appropriately and scientifically.
I asked that question because I'm a rheumatologist, and I know in some of the, there's some information about silica dust causing scleroderma like syndrome and drug-induced lupus, medications that cause lupus. So I guess because they're not studied doesn't mean the information is not available.
Exactly.
So,
Yeah.
but thank you for answering that
Yeah.
question.
So there are actually 3 or 4 questions on the bad luck theory article in the New York Times. So I'm trying to synthesize those questions, but perhaps it's more just, I think they're requesting comment from the panel in reality about the article, what they think about whether or not bad luck is actually a misnomer.
So there's been a controversy running in the field of environmental medicine for at least 40 years and probably longer than that, but that's as long as I've been in the field, about as to how much of disease is caused by genetics and how much is caused by environment. And people get very invested in one answer or the other. I think a lot of it depends on how a person is trained. If somebody in medicine has trained as a geneticist, they tend to think that genetics dominates. If they're trained in environmental medicine, they tend to think of external factors. The truth of the matter is that most human disease, whether it's cancer or anything else, is probably the consequence of an interplay between genetic factors and environmental factors. So at either end, there's some pure example. So for example, on the purely genetic end, you have babies who are born with single gene disorders like Tay-Sachs disease, sickle cell, Gaucher's disease, and there's a long list of these conditions that affect relatively small numbers of children that are pretty much purely genetic diseases. Unfortunately, a child is dealt a bad hand of cards at the moment of conception and the child gets a disease. That's maybe 10% of all human disease, give or take. And at the other extreme, there are people who are hit with an overwhelming environmental exposure. The child who gets lead poisoning, the insulation worker who's exposed to asbestos, the person who gets a heavy dose of radiation like the atomic bomb survivors, where the environmental factor predominates, and that's maybe 5 or 10% of all human disease at the other end of the spectrum. But the 80 or 90% that's in the middle is probably caused by the interplay. So what causes those mutations? Is it simply aging, and the DNA gets tired and a mistake is made in copying as cells divide? Yeah, maybe. But maybe also it's some external factor that we've not yet been smart enough to identify that causes those unfortunate mutations that result in diseases like cancer. I think my own view of that article where it said 2/3 of it is bad luck, therefore throw up your hands, have another drink, and don't worry about it. It's not good public health. I mean, good public health says it's almost like the prayer of St. Francis: change what you can, accept what you can't, and then live happy. And in this case, in public health, you try to lose weight, you drink a little less alcohol, stay out of the way of radiation, don't put an artificial log in your fireplace, and try to work out 3 or 4 times a week and do your best, but don't throw up your hands and say you have no control, and don't smoke. Yeah, absolutely don't smoke. So, yeah.
I agree wholeheartedly, and I'd just like to add to that. I think the difference between measuring environment and measuring genetics is very stark. If you can measure your genes at any time in your life, your genotype is, your DNA sequence is the same the day you die as the day you're born. Your environment's constantly changing, and some of this concept of bad luck is simply because these things often are insidious. They don't provide overt symptoms, or even if you had some symptoms, you don't actually recognize what it was that caused those symptoms. And that's really what we're calling luck in this case, when in fact it is something that is potentially measurable and something that actually can be prevented. You can't change your genes, but you can change your environment. And I think the take-home message to me is that we need to have better measures of the environment that also factor in, as Susan said, the timing of the exposure. And that's really what we're trying to do in our own research here at Mount Sinai, is actually understand both the dose that you get exposed to and when it happened, and trying to predict what happened in the past, which sounds like an oxymoron, but that's actually what we're trying to do in our research.
Sorry, can you just clarify the point you said about your genes? Because isn't epigenetics telling us our genes also change?
Epigenetics is I think there's a comment, because it has the word genetic in it, there's this idea that it's similar to the science of genetics. The science of genetics actually studies the sequence of DNA, and a mutation is a change in the sequence. An epigenetic change is a change in, say, some group that gets added to a chemical, like a methyl group. And it's very specific to the tissue. So if you also have to measure it in the tissue that you're interested in. It's actually the science of why a skin cell is a skin cell and a heart muscle cell is a heart muscle cell, even though they have the exact same DNA sequence. And it is responsive to the environment, but it's a very different field than genetics. And I think in some ways I wish it had a different name, because it gets confused with genetics all the time. And it's not. There is some, and it gets even more confusing because there are a few instances where it's been shown to be transmitted, like genetic diseases are transmitted. But most of the cancers we're talking about don't work that way. Because they're somatic tissues. In order to pass something on to your children, it has to be in your eggs or in your sperm cells. So we're not talking about changes that occur in those cells, so it can't really be passed on to your children that way if it's an epigenetic phenomenon. Please discuss the risks associated with radiation of mammograms. How should women over 60 with no risk factors, should they receive mammograms?
Yeah, I'm glad whoever asked, because it's a great opportunity to dispel some of the myths around one of the most useful screening tests we have. Absolutely, we've already heard from the panel that radiation, which is complicated. It can cause cancer, but we also know radiation can cure cancer. We treat women with breast cancer with lumpectomy and radiation, for example, so it's complicated. The issue is that mammograms are associated with a small dose of radiation, but it's also important to know that, as we talked about, there is radiation, just like the electromagnetic stuff, in the environment. Women who live at altitude are at higher exposure to radiation. Women who fly on airplanes, stewardesses, or I guess they're called flight attendants, right, are exposed to radiation. And so there are very, very numerous environmental factors that expose one to higher or lower doses of radiation. So it's really, you have to put that into context in terms of dosing. A mammogram is associated with all of the improvements that have been made since the 1980s in the technology. Mammograms are one of the lowest radiation dose exposures of all diagnostic tests that we do. So, for example, a mammogram, a standard digital mammogram, is associated with the radiation exposure of about 10 to 20 plane flights, okay? And typically most women do that once a year. And so, for sure, and keep in mind, mammograms are the only test that has ever been shown conclusively to be associated with the reduction in dying from breast cancer related to doing yearly mammograms. I think it's also important to know that if you put it into perspective, people with who are at increased risk for lung cancer, smokers and so forth, get screened with chest CT. A chest CT is associated with, one chest CT, about 20 times the dose of radiation from one mammogram. So if you look in the spectrum of all the radiologic tests people do, mammograms is one of the lowest. Now, interestingly, we at the small plug for the Dubin Center, we were one of the pioneers in introducing in our center a new technology called 3D mammography, which instead of taking two pictures of the breast, it really kind of pages through the breast, almost like the pages of a book, that can pick up more cancers because of the risk of obscuring cancer with tissue overlap, and also, more importantly, can reduce callbacks for additional mammograms based on the facts that it kind of separates tissues. So if you see a really dark spot on a conventional mammogram, you can look in the separate pictures and maybe that dark spot is just this tissue overlapping with this tissue, which ends up being nothing. So while we feel that even though 3D mammogram is associated with a slightly higher dose of radiation, that if you read that would make a woman reluctant to get it, the net effect by reducing callbacks and additional mammograms and additional ultrasounds and additional biopsies, the net effect is possibly an overall reduction in radiation exposure to the vast majority of women. The radiation, so the take-home message is the radiation exposure related to mammograms should not be a reason to opt out. It is really relatively small overall, and for the vast majority of women, the benefits outweigh the risks. There was an interesting and really, really sobering study done in Boston looking at unfortunately, the women who died of breast cancer there. And if you look at all the women who died of breast cancer in the state of Massachusetts in one particular year, 70% had never had a mammogram. Okay. Another 5% had not had a mammogram within the previous 2 years. Now, 25% had been conscientious and they had biologically aggressive breast cancers, but it shows you the power of a mammogram and how really very, very critically important it is in terms of reducing the risk of dying from breast cancer and breast cancer screening in general.
What is the relationship between oral contraceptives and breast cancer, and is there evidence of a window of susceptibility for younger ages?
Yeah, I can address what we know about the risk, and then perhaps Phil can. Yeah, there is no known association between oral contraceptives and the risk of breast cancer. Interestingly, it does reduce the risk of ovarian cancer. We think it's because obviously what it prevents is ovulation, and so eggs leaving the ovary in terms of ovulation cause trauma to the ovary and may be one of the sources of DNA damage and one of the sources of increased risk of ovarian cancer. So in general, we don't discourage our patients with high risk of breast cancer to go off birth control. That being said, we do usually take our patients who are diagnosed with breast cancer and, to err on the side of caution, ask them to discontinue any kind of exogenous hormone. So if you've been diagnosed with breast cancer, we usually recommend going off hormonally based contraceptive measures, but women who are not diagnosed with breast cancer really are not at increased risk for breast cancer based on their oral contraception.
All right. So this relates to a bigger thing, and Susan, you may want to comment on this too, but the general notion is that the more estrogen a woman's breast is exposed to over the lifetime, the greater the risk of breast cancer, all other things being equal. So what does that mean in practical terms? It means that the earlier a young woman starts menstruating and the later she the longer she goes before menopause. Either of those factors stretches out the amount of time that her breasts are exposed to estrogen. On the other hand, the more babies she has, the less estrogen the breasts are exposed to, because every time she's pregnant, the hormonal pattern changes, and also lactation changes hormonal patterns. And so both pregnancy and lactation reduce risk. So early menarche, late menopause, increased risk, and lots of babies and lots of nursing reduces risk. And then compounds that may be estrogen mimics, some of the endocrine disruptors that Susan was talking about, or that otherwise alter estrogen metabolism, increase estrogen levels in the woman's body, as does obesity, as does alcohol. So the common denominator that ties all those risk factors together is estrogen. So now what about hormone replacement therapy?
Right, so interestingly, hormone replacement therapy has been a source of controversy in recent years. Absolutely, certain kinds of hormone replacement therapy increase the risk of breast cancer, and it gets complicated, and it's a little bit of a catch-22. What the most recent data shows is probably estrogen alone doesn't much increase the risk of breast cancer, but estrogen and progesterone combination do increase the risk of breast cancer. Here's the catch. Without the progesterone, the estrogen alone increases the risk of uterine cancer. So you've got this catch-22. It's an easy decision, for women who've had their uteruses removed for whatever reason. You usually can put them on some estrogen replacement and feel relatively safe that they're not increasing their risk of breast cancer by much. Of course, a lot of it has to do with length of time. And, with the women's, with the nurses study that came out and the data that came out, this is just about 5 years ago, there was a huge kind of upheaval in how we thought about estrogen replacement therapy. Before that, everyone really thought there were so many benefits to hormone replacement therapy, we should just put it selectively in the drinking water of probably all women. I mean, there was felt to be benefits related to bone density, to cardiovascular disease, to mental health and cognition and Alzheimer's. And the small trade-off was a slightly higher risk of breast cancer. So when the data came out a few years ago, what that showed is actually the cardiovascular was, a lot of women were put on estrogen for cardiovascular health. The number one killer of women in this country is not breast cancer or any cancer, it's cardiovascular disease. And so what that study showed is that actually hormone replacement therapy is associated with an increased risk of clotting and an increased risk of cardiovascular disease. And so that threw all the data on its head. And that led to a lot of women who had been on hormone replacement therapy and a lot of gynecologists who are prescribing it to rethink everything and revisit it on a case-by-case basis and say, look, if we're not giving it for cardiovascular health anymore, and it is associated with an increased risk of breast cancer, and there are other medications now for bone density, why are we really giving it? And in the end, now the only real reason to give hormone replacement therapy is kind of to bridge the side effects of menopause. So intolerable hot flashes, and vaginal dryness and some of the other things. But what's happened over the last 10 to 15 years is we developed armamentariums of other medication that can selectively address some of the side effects of menopause. And so the rationale for putting someone on hormone replacement therapy has become narrower and narrower. That being said, there are definitely women who literally can't function, who need to function at a high level, and who feel that menopause has completely ruined their lives. And in those women, of course, hormone replacement therapy can be considered. It's trickier when those women are at increased risk for breast cancer for other reasons already. And a lot of it is just about weighing the risks and benefits for any given individual. I think of my patients as adults and capable of making their own decisions for themselves. They know themselves better than anyone, and my job is to to provide the information that when there's a balance between risks and benefits, it's up to them to decide. There are many women who understandably would accept a small increased risk in breast cancer to have a better quality of life if menopausal symptoms for them are really interfering with the way they conduct business on a day-to-day basis.
Is there evidence that breast cancer rates have gone up over the last 10 to 20 years?
They have, but the flip side is that mortality from breast cancer has gone way down. So it's a balance.
Although that would seem to argue for environmental causes.
It would.
So next question is, what is the role of race and ethnicity in breast cancer risk and aggressiveness of the tumor?
So there's been a lot of investigation with respect to the differences in incidence rates in Black and white women in particular. And so in younger ages, in premenopausal breast cancer, there appears to be a increased, okay, now let me get this straight. I can see the graph. So there's an increased rate of breast cancer in African American women at younger ages. And then when you pass menopause, what you see is an increased rate in mortality from breast cancer in African American women. So that there are definitely black-white differences, and this has been well studied, but it's still unclear, except for sort of the socioeconomic associations that we see in breast cancer, what is accounting for this differential.
The only part that I can add to that, which is absolutely true and what we see, is that it has been for a long time now a subject of debate as to whether or not African American women who have a poor survival or prognosis from breast cancer, whether that is related to biologic facts related to the breast cancer. For example, I talked a little bit about triple negative breast cancer and how that's affects a large number of BRCA1 positive women. Well, guess what? African American women also have a larger percentage of triple negative breast cancer, which is much more difficult to treat and considered much more biologically aggressive. If in the general population, the number of cases of triple negative breast cancer is responsible for about 10 to 15%, among African American women, it's more like 30%. So part of it is probably explained by they have inherently more biologically aggressive cancers. Another part of it is whether or not there is some component of access to health care, regular screening, etc. So it's a very complicated issue, again, with a question of interaction of perhaps hereditary and environment playing different roles.
Is there any evidence that the types of chemicals found on clothing are associated with cancer and also used in dry cleaning?
So the great dry cleaning chemical, the most commonly used chemical in dry cleaning, is called perchloroethylene, tetrachloroethylene. It's a nasty solvent. It's certainly toxic to the brain and central nervous system. Because it's a solvent in the same general family as alcohol, ethyl alcohol, and is metabolized by the liver, it's theoretically possible, I suppose, that it may somehow increase risk of breast cancer because it has that same enzymatic interference that has been reported for ethyl alcohol. But fact is, I'm not aware of any studies that show it. One of the things that a piece of advice we've given to families, if they're worried about the fumes that you often smell on dry cleaning when you first bring it home, a simple thing to do is to take the clothes out of the plastic bag, hang them in some part of the apartment or put them on the porch, someplace where the family doesn't go, and give them 6 or 12 hours to off gas, and then the chemicals are gone, because they're pretty volatile, and when they're gone, they're gone. Or another thing you can do is don't do dry cleaning. Wash your clothes the old way.
are wearing clothes like new, going back to school or whatever. I was very concerned about children and infants being exposed to people not washing the clothes, and there are a lot of chemicals on those clothes to keep them looking new and stiff.
Yeah, brand new clothes have things like formaldehyde in them that are toxic in various ways, even if they don't cause breast cancer. Yeah.
Unfortunately, several of these questions, I should have asked this one before Dr. Port left. It was a question
She
about
had to go see
detecting
patients,
ovarian
so, yeah,
cancer.
yeah.
Unfortunately, I think our expert on detecting ovarian cancer has left the room. This one is also clinical. Here's one for Dr. Landrigan. How is the CHC working to educate the community surrounding Mount Sinai about their services and the role of environmental health long term?
We believe we have a serious responsibility to engage in conversations with the many communities that we serve, with the community of our patients, with our geographic communities, which means East Harlem, South Bronx, Upper East Side, and the broader community across New York City, especially as Mount Sinai continues to grow. And so we actually have people in the Children's Environmental Health Center whose primary responsibility day to day is to educate. Katie Southwick, whom you met, who when you checked in, the young woman who was handing out the cards, does a great deal of education. Damaris Agu, who is in our what we call the Pediatric Environmental Health Specialty Unit, which is the clinical arm of the center, does a great deal of public education. Sarah Evans, who I saw earlier, I can't tell if she's up there now with the lights, is a trained neuroscientist who devotes herself to health education. There's Dr. Carol Horowitz in the Department of Health Policy, Dr. Maida Galvez and her team. There's a whole crew of people who spend significant portions of their time. Bob and I too, and Susan. The fact that we're here this morning with you all is testament to the fact that we think that communication is a big part of the deal. Public health, after all, if we were to do public health research in the laboratory and keep it in the lab and keep it some kind of secret knowledge and never transmit it to the public, it wouldn't do a whole lot of good in terms of improving the health of the public. So part of being a public health doctor, an epidemiologist, is transmitting knowledge to the public. So we do a lot of that, a lot of education, and we will continue to do so. And by the way, it's a two-way street. We learn an awful lot from the people with whom we work. I can't tell you how much I've learned about breast cancer from talking to my friend Karen Miller from the Huntington Breast Cancer Action Coalition. So
this will be our last question. I apologize if we didn't get to your question. Besides switching personal care products or laundry products, what specific measures can we take to protect our homes from endocrine disrupting chemicals such as phthalates?
Well, there's a lot of literature out there that can give you information on what products contain phthalates if you're trying to avoid specifically phthalates. In personal care products, there are databases. If you have internet access, the Environmental Working Group has databases where you can put in your product and see what the ingredients are. One of the key things is to look at the ingredient lists on your products. And certain of the phthalates will be listed as ingredients. However, if fragrance is listed as an ingredient on a product, there's no obligation to list diethyl phthalate, for example, because it's considered part of the fragrance. So you can, if you avoid products that contain a fragrance, then you are most likely avoiding exposure to diethyl phthalate. Products do now, because of the great public awareness, label their products as phthalate-free and many other chemical-free. You should take that with a grain of salt, because there is no regulation over the ingredients in most personal care products. So it's one thing that you have to think about. With respect to household furnishings, There are anything that is vinyl is pretty much guaranteed to contain diethylhexyl phthalate because it's sometimes up to 40% of the composition of vinyl. So it's in there to promote flexibility. Shower curtains, vinyl shower curtains. There was a study looking at 7 different shower curtains, I think, that were purchased maybe at Target or, just a very accessible kind of department store, and they measured the content, and all of them were found to contain DEHP. So vinyl window blinds and vinyl wall coverings are all potential sources of exposure. So the question is, we can't live in a glass bubble, and we can't line our floors with glass so you have to try to use alternatives. There's lots of alternatives that you can consider to use, but you're not going to necessarily renovate your entire home to remove it. So it's all within, you have to think about how practical and efficient it is. So, you can start with small things like using fragrance-free products and work your way up from there.
So this really concludes our morning. Let me take a minute and try to summarize and then do a few things. So what have we done this morning? We've been through our speakers. We've been reminded of patterns of breast cancer in the American public, the epidemiology of the disease, more in older women, highest rates in San Francisco, but high rates also in the northeastern United States. We were reminded of the genetics of breast cancer, the great risk that's conveyed to certain women in the population by BRCA1, BRCA2. I think one of the most significant things that Dr. Port said is that something like, I think the number she said was 70% or 80% of women who are diagnosed with breast cancer have no family history whatsoever, which means that every woman over the age of 40 has to have regular screening. We learned about environmental factors. We know that alcohol is a proven risk factor for breast cancer, obesity. Susan reviewed the very suggestive evidence for polycyclic aromatic hydrocarbons, also known as soot, black soot from burning. We talked about phthalates. Something that wasn't said overtly, but the discussion of melatonin that Susan engaged in may tie to the fact that people who are night workers, whose day-night cycle is reversed, melatonin rhythms are off kilter, are at increased risk for breast cancer. And I can't read my own handwriting. And we reviewed the data on electromagnetic fields. And so we learned a lot. I think the take-home lesson here is that we know that incidence of breast cancer is going up. The good news is that mortality is going down, but the incidence, the number of cases per 1,000 women and men, is going up. Going up certainly too rapid to be genetic. Nobody thinks it's better diagnosis. It's a real disease. Something is going on, and therefore I think as much as anything else, the bottom line that comes out of a symposium like this is, number one, avoid the specific known risk factors, and then beyond those specific factors, lead a prudent life. Minimize your exposure to pesticides, cut down your exposure to plastics where you can, exercise regularly, keep the weight off to the extent you can, control alcohol. Those are things that we all try to do, imperfectly of course, but as well as we can, to take control of our lives and try to. The goal at the end of the day is to live happy, productive lives, to have beautiful children, and to raise them up to be smarter than we are. Right? That's what it's all about. So with that, I probably can't top that one. With that, I want to thank our speakers. Thanks to Bob Wright. Thanks to Susan. Thanks to Dr. Elisa Port, who apologized, but she had to run see patients. Thanks also to our staff, to Katie Southwick and to Jackie Lightseas and to Alvaro McBean for having put this nice morning together. And we'll hang around for a few minutes if any of you want to catch us. But wanted to get it over with so those who have to leave can leave. Safe home.